All right, I'm supposed to get started, I believe. So it's nice to see everybody here. I'm Ann Rust. I'm one of the trauma surgeons over at Good Shepherd in Hermiston. My background is small town. I was telling some people up here, I'm from North Idaho, in the small town of Sandpoint, Idaho. When I grew up, my dad was the only doc in town with his partner. So everybody in town was delivered by him. Everybody that got in a car accident was taken care of by him. So that was medicine for me when I grew up. So rural medicine is an entirely different type of medicine than big city. When I trained, I went out to the Midwest to Creighton University, which is in Omaha, Nebraska, a million people center, and it's kind of the center of the US drug trafficking. Texas is south, Chicago is north, and we're dead center east-west. So we had quite the interesting gang and trauma. MS-13 was there back in the 90s when I trained. It was pretty common to get doors pried open and patients thrown in. So I had a fun time in trauma, but I really, really missed rural medicine. It's just a completely different cup of tea. When we were talking about our frequent flyers, the EMS all knows, the ER knows, and it's just a very different environment. So I really enjoy coming out for rural medicine. I give a lot of talks for abdominal trauma, but it's frequently for providers. And this section is really rarely talked about. So I actually stopped before we get to the hospital because I think that's the part that's missed a lot. And even in talks I'll go to, they talk about hospital, which has nothing to do with you all. I mean, it does, but it doesn't, right? Like you don't get the CT scan. Like, see the CT scan. You're like, actually, no, I don't. So I tried to leave that part out, or if I did, I matched it with the things that you're going to see in the field. And that's my goal, is what should trigger your brain when you go up to an accident? Like, what is it that should say, oh my goodness, this is somebody that's going to have abdominal trauma? Okay. Please stop me along the way. I am always the one in the room that does this. And everybody's like, oh, she's asking another question. So questions I enjoy. Sometimes I think differently, approach things differently. So if you have a question from your perspective, there's probably somebody else that has that same question. Question number one, how do I get this thing to go forward? Wait, nope. Okay, ready? Nope. Wait. I would, but okay. If it doesn't work, it's no big deal. Okay. Are you sure? Oh, okay. Yeah. So these are the topics I wanted to go through. Briefly, the definition of trauma, more the anatomy, the mechanisms of injury, common injury and evaluation in the field, and then management in the field. And I'm stopping there. Okay. Fast scan, CTs, all this stuff done in the ER. We can talk on that a different day. So definition of trauma. Trauma by definition is just a tissue injury due to some sort of violent or accidental action that happens to the body. And it has to trigger what's called the hypothalamic pituitary adrenal axis. And the adrenal is probably the most important part that most of us understand. This is a cortisol. This is a steroid response that the body, it's like squeezing your adrenals, your epinephrine, your adrenaline, and your cortisol go off. And so that's what makes people able to have a lion chewing on their leg. And they're like, oh, look, the lion's chewing on my leg. So trauma in general has to set this axis off. And the whole point of it is to restore what the body normally does, so that you can function through that trauma. This is absolutely a common theme, and it's automatic. People don't turn this off, they don't turn it on, it triggers on its own. But more importantly is how a person's response goes is not always the same. So we sit here in these classrooms and we talk about what to expect, and that includes about 70% of people, which is 2/3, roughly. Right? So for every 3 people you come on, one of them is not going to behave normally. We can even make it 4. So for every 4 people you come up on, 1 is not going to follow the rules. All right. And it's really being able to, that's why we have this education. That's why we're trained. It's so that we can figure out who the 1 is. Right. And that we catch them and take care of them the same way as the other ones that are quite obvious. In general, we categorize trauma into three areas of penetrating, blunt, and decelerating injuries. Blunt trauma is simply any force striking the body. Penetrating is any force entering the body. That's the two differences. And the most common location by far of any blunt trauma is the belly. Okay. Questions about that? It's basically straightforward. I think most of us know it. Defines it in a little more straightforward terms. The anatomy. So interestingly, the abdomen, the abdominal cavity, is actually the only cavity in the body that has vital organs, things that we need to survive and live, that are unprotected. Every other vital organ is completely and utterly protected. The brain, we consider the most vital organ, right? You can traumatize the brain only and alters you quite a bit. It's surrounded in a big, thick skull. Some people's are thicker than others. My oldest brother would be in that category. The rib cage has the heart, the lungs, and actually 2/3 of the liver, a lot of the spleen, half the kidneys. So we are super well protected. The pelvis starts pretty close, and all the major blood vessels that are prone to shear injury, deceleration injury, all the injuries are all protected. And then our long bones, all the major blood vessels are buried under the muscles next to the bones. So if you think about it, we're pretty well engineered to withstand a lot of trauma, except for this section right here, the in-between in the brown. So intra-abdominal organs are jarred, shaken, and moved in this area. And you can see the back is a lot more protected from the hips to the rib. And then we have this short flank area, but this is really the area that takes the most trauma. And why is that of concern? We talk about perfect anatomy, right? How many people look like this when you drive up? And we talk about what's all in this area, all the organs on top. And then if we remove the organs, we see the major blood vessels in the spine. And this is important because there's a vast amount of room inside this space, okay? So how much relative room? Because to me, room is all relative, right? You can have a really big house, but if you have 40 people in it, relatively, it might not be that big. So the average human blood volume is about 70 to 90 mLs per kilogram, or roughly for a 180-pound person, 6 to 7 liters. So is that a 2 liter? Is that a liter or 2 liter? It looks like that looks pretty big. Okay, so roughly 2 liters. So 3 of those is how much blood we can carry, that we carry on average, 3 to 4 of them in our bodies, right? The abdominal cavity can hold 15 liters. So your abdominal cavity can hold 3 times the amount of blood that you contain in your bloodstream. Right? From a trauma standpoint, that's kind of a big deal. Right? So just from the beginning, we know it's not protected. There's some really big things in there with lots of blood flow, and it can hide it really easily. That is why surgeons and trauma teams are so interested in blunt abdominal trauma. The pelvis, just from here down, can hold 5 liters. So in most patients, you can bleed out from a pelvic injury, just a pelvic injury, right? And slow bleeding, we can handle really well. Slow bleeding, we've all seen it. You go pick somebody up, you're like, oh, you're kind of palish. You look kind of white. No, nothing in their eyes. They go to the ER, they get their blood checked. It's like 4. Like, oh, yeah, they're kind of low. That did not happen fast, right? That had to be the sink that's trickling, and it's just happening over months and months and months. And somehow our body can go from 12 down to 4, lose 3/4 of this tank, and still be walking and talking. That's impressive, isn't it? I mean, again, we're the best built engineered thing there is. But if we lose it fast, even half our blood volume, our heart can't handle it. We'll go into arrhythmias and we'll die. And again, you've all seen that as well, right? So blunt abdominal trauma is a big topic because of this concept, Okay, this is more the realistic abdomen we all get to see. So this is a person I'm showing. I'm pointing at the first picture. This is somebody that's holding about 12 liters of abdominal fluid in their belly, walking around. So that's somebody with ascites, right? And skin can stretch tremendously. This is after we drain them. Right? It's incredible. That's 12 liters of fluid like nothing. And he walked in, hello, hi, no problem. And we didn't even get it all out because he can't. Yeah, exactly. This is more the belly we usually see, right? Somebody has a few wrinkles. This is not me, thankfully, yet. Has an old scar. It's hard to tell the anatomy. So it's a little more difficult for the realistic person. You're pulling up, they're laying down, so it's a lot different. So we're going to talk about things that you can look for that can help around these issues that we all run into. So how impressive are these solid abdominal organs, right? We talk again about the fact that you can hold that much fluid, but how much are you actually able to bleed into the belly, and how fast can you bleed into the belly? All right, so let's go through the liver. First one, every minute, your liver filters 1 liter of blood. In 60 seconds, we have all put an entire liter through our liver. In 1 hour, we go through 22 gallons of blood through our liver. In 24 hours, we go through 250 gallons of blood through our liver. So you can see how a liver injury can absolutely kill somebody, right? And the entire thing can bleed in the belly, and maybe we can see it, maybe we can't. All right, kidneys, they can do about 1 to 1.3 liters of blood per minute. So they're actually faster, but they're smaller, and our body will cut them off quicker. So we don't lose quite as much volume. You can lose about 5 liters from a kidney injury within an hour. The spleen is about 150 mLs a minute that it filters, and so it's about 15%. It's roughly the same concept as a liver, but 15% of the volume. So, you know, about 2 gallons or 3 gallons of blood in an hour. So these are the organs that can be damaged, that can kill a person within an hour. Okay. So remember that whole golden hour concept? This is where it comes from. Okay. Even small injuries we talked about can result in high volumes of blood loss because it's not the size of the injury, it's the location of the injury, right? That is the most important concept with abdominal injuries, because we can stretch so far. You saw those pictures. If the body doesn't naturally tamponade, I'm sure you've heard that term. That means if it doesn't stop itself from bleeding, it will continue to keep bleeding and bleeding and bleeding and bleeding. All blood loss stops at some time. That's the trauma surgeon motto. So this just talks about the anatomy a little bit, about the size and location of things. Here's your liver way up front. It's very, very large. You'll notice this pesky structure right here. That is the spine. That's a bone. That's a very, very hard surface. There's a spleen. There's a couple kidneys. So this spine, as you see, it runs all the way up and down. It's a beautiful structure. It allows us to walk and do the chicken pants, whoever was going to get me to do that. But there's a problem. It's also a very hard surface that goes up. It's a perfect log to snap things on. Okay, we're going to talk about how this becomes a problem with this beautiful concept of restraints and seatbelts. Okay, lots of abdominal organs, all of these lovely bowels all up in top. So there's a lot of stuff inside that belly with a backboard on the back, muscles, and a spine in the middle. Okay. So mechanisms of injury. Any questions about the anatomy? Right? Do we care what the blood vessels' names are? No. They got lots of names, right? Lots of names, lots of paths. Do I care Where they go through, how they, no, all I care about is the amount of blood that can go through each of those organs and how they can get harmed, right? They're not protected, we've got a log in the back, we can have someone die within an hour. Okay, so mechanisms of injury. Most of us know these things. The number one cause of blunt abdominal trauma in the United States for both adults and kids is motor vehicle accidents, right? Lots of Americans drive. We have more vehicles in the US, I think, than all of Europe, and I can't remember the number. It's like most of Asia. We have a ton of vehicles. Why? Because we like our space, right? We don't like each other. No, in all that seriousness, you look at places like Germany, France, no one owns homes. They all live in apartments. They all are in towns, and they all walk because they live right on top of each other. So they don't really have a lot of vehicles. I drove from Hermiston to Pendleton, and I'll drive home, which is another 2 hours from here. And of course I'm gonna drive. I'm not that healthy, I'm not gonna ride my bike. Yes, yeah, and even in the cities, public transit is really difficult, and there's a lot of accidents caused by public transit in the cities, if anyone's driven or been on the roads in some of the bigger cities. The number 2 assault for adults or number 2 cause is assault. And in the big city, this was always the tagline. These 2 guys came out of nowhere and jumped me, right? We always laughed and said, if we ever found these 2 guys, we would solve all the assault trauma around. It's always in the middle of the night, and they're minding their own business. Don't forget that part. For kids, it's actually bicycles. Bicycles cause a tremendous amount of harm for abdominal trauma, and we have the evil handlebars, and we'll talk about that. Other rare causes are falls, sporting accidents, and then there's some industrial accidents that occur that are on that list. So bicycles, this is the very, very typical scenario of a young kid riding a bike. They can have a helmet, right? They can have pads, they can have knee pads, arm pads. Mama can put this kiddo in every possible potential cover up, and there's nothing for this belly. And those handlebars are right at the wrong height, because that's how you measure a bike, right? So they go and bam, the sucker hits them right in the belly, right around their belly button. So where is that? Remember we talked about this troublesome spine, that dead center. This lies right over the liver and the pancreas. So the most common handlebar injury is a damage right to the pancreas, liver, and then right in between those 2 is a small section of small intestine. So small intestine injuries, the pancreatic and liver injury, are really common for a little kid riding a bike. That's true if they get hit by a car, because they tend to go up over the handlebars. True if the scooters handlebars are about the same length. So handlebars are actually one of the most common devastating injuries for kiddos. And here's the picture here. You can see this is the edge of the liver. The pancreas is down here. The spine creates that backboard for that handlebar to compress and injure that small bowel. Okay. And these are CTs of little kids who have pretty impressive injuries. And these are, speed is not relative to the injury. Kids can be going fast, but actually they can be going just as slow too, because it's really the compression on that. There's the liver, major blood vessels right here. This major blood vessel drains all the blood back into the liver. If they hit on the other side, it is known to tear this thing. It's called an IVC injury. It is very, very difficult to stop. And these are kids that walk in the door and don't make it out of the hospital. Solid organ injury. You can see central, where do we hit people? You don't hit them in the ribs, right? If you're gonna hurt somebody, right, the technique I've heard, no. Or in the side where the kidneys are, flank injuries, across the front. Again, very common to hit those solid organs, so assaults. These are, also common injuries of people falling over, hitting across That guy looks like he's having fun. This looks like a dare. This was a thing for us in the 90s. Kids were hitting each other. I don't know if y'all remember this. They were doing cedar blocks. They were doing all kinds of stupid crap to each other. Now it's like Tide Pods, and then it became cinnamon. Yeah, you leave teenagers to their intelligence, and we get that. Common to see bowel injuries. Again, that spine is right there, causing it to be a surface where it can get injured. Also the kidney in the background. This is a spleen and a kidney injury, all from just an assault. Right, we get a lot of them. I know you guys do too, from our friendly penitentiaries in town. Right, you go in, people are down on the ground, and there's a kick. Don't forget that. That is a really common injury. We see them down, they're bleeding in their face. And so we always want to make sure we're remembering the secondary assault injuries that can occur. All right. Number one for blunt abdominal trauma, we talked about the car accidents. Interestingly, I like this picture. I picked that for you guys. Yeah, that's a bad day. Yes, I'm not sure if they're rolling in to be like, yes, we're here. Not really sure on that one, but fatalities. So how many cars are actually on there, and how many people get in car accidents annually? Because we talk about this all the time, right? So added in 2020, there was 36,000 fatalities, right? How many crashes? So 5 million. 5.2 million crashes happen in a single year across the United States, right? So out of 5 million, this many pass away instantly, don't need any of our services typically, or if they do, it's not for very long, but 1.5 end up with severe injuries, require level 1 or 2 trauma center level injuries. Right? Enter our significant trauma programs, and 3.6 have property damage or some other minor injury. So most car accidents end up with something happening to them, right? If you just go by the numbers, you are more likely than not to have an injury coming out of a car accident. 1 in 65 people will be involved in a car accident annually. How many people are in this room? So at least 1, if not 2 or 3, are going to get in a car accident this year. 1 in 200 will have a serious injury. So, sometimes we think, yeah, car accident. This is why we pay attention. This is why we want to remind ourselves, don't take for granted when you're driving up, right? The speed is not always the problem. Kids with bike accidents. And when it's super interesting, which we'll talk about next, we all go, yeah, that person lived, right? Why? Because we do live now. Oops, I went out of order. So what is injured with car accidents? 40% of the time, it's your spleen, kidneys, intestines, liver, retroperitoneal bleeding. That means behind all the organs, next to the muscles and spine. Not the intestines, but the things keeping the intestines alive, the diaphragm, the bladder. So 40% of people will end up with some sort of splenic injury in a car accident. So do restraints make a difference? Right? I give these talks. My husband's a retired police officer, so I always ask him, what would you want to know? This was his. And I thought it was a really good question, right? What have restraints done for us? Seatbelts and airbags give a 68% reduction in death. Death. That's a really important concept. They save lives. So it means you are far more likely to come up to a really bad car accident and people are alive. Okay? 8% reduction with airbags. It's not as impressive as the seatbelt. And interestingly, it protects women more than men. I don't know. There's so many different reasons we could have theories, but this is well tracked. 11 countries doing studies. So what does this mean to you and I? More people stay alive more people with injuries, right? That's what it means. It doesn't necessarily stop injuries as much as it stops death, okay? So what are we seeing because of restraints are injuries we never saw before, right? These people would have died and now they live, and now we've created injury patterns that never occurred. Seat belts, abdominal injuries have gone up. Even though, and I'll show you the next slide, people that wear a seatbelt are less likely to have one, the total number of injuries has gone up. Does that make sense? Some statistical math. It's confusing when they say, oh, abdominal trauma has gone down with seatbelts. Yes, that's true, but more people are living. So more people have abdominal traumas. Yes, in theory, it's better to have an injury than death. But for us, that means we're going to see more people with abdominal injury because they didn't die, right? Lumbar fractures of the spine also going up. Airbags, oh my goodness, facial injuries through the roof. These things are smashing people's face, and we learned, all us old school people, 10 and 2 are now, what is it? Yeah, I don't know. My kids went through it a few years ago, and so, yep. Cardiac injuries. So the blow to the chest is stopping the heart, and the heart keeps moving, and so people are getting cardiac contusions to the backside of their sternum. And then upper extremity burns from the powders, right? Most of us wear pants, so they are not as bad, but the upper extremity burns we're seeing. So is it worth the 8%? I don't know. The CDC seems to think so. So if you look at the people who survive, again, a lot more people are surviving. If we look at those and the cars are better engineered, you are much less likely, if you're wearing a seatbelt, to have a major injury. So we still absolutely positively recommend wearing seatbelts, right? Any injury is also much less because of the lower speed accidents, right? That's really where this comes from, is not the high speed accidents, it's the low speed accidents. You're driving through the Walmart parking lot and you don't buckle up and take an injury. But we see a small decrease with facial and spinal injuries, but there's absolutely no difference for head traumas, neck traumas, thoracic trauma, upper extremity, lower extremity trauma, whether you're wearing a seatbelt or not. All right, so how do we evaluate these in the field? So bruising. Bruising is often seen in the field. Bruising absolutely means there is an abdominal injury. They are one-to-one. What type of injury? This is the types of injury. But bruising always equates that there was an injury in the belly. Okay. Yeah. So these are all the fun names that have developed because of seatbelts and all the other ones. This one is a frequently missed sign, especially for you guys, because bruises don't always show up right away, right? If you're on a scene, it's in town, and you're there, you're popping the person in your rig, and you get 10 minutes to the hospital, what's the likelihood that you're going to start seeing the developing bruises? Very low, but this sign is actually fairly common. This is referred pain to the shoulder. They have an injury to their spleen or their diaphragm, and it hurts up here. Same thing on the liver. If they have a liver injury, they might hurt at their other shoulder. And that is because the nerve that goes to the diaphragm has a Y connector. Comes to the brain, and it Y connectors out, goes to your shoulder, and it goes to your diaphragm. So either one are triggered, your brain has to interpret that, and it always tells you your shoulder hurts. Anybody had abdominal surgery and their shoulder hurt after? Yeah, I swear we don't put you like this or this in the operating room. It has everything to do with gas trapping underneath that diaphragm, irritating it, and the brain cannot tell the difference. So you come on the scene with somebody with a shoulder pain, that should make you think, man, maybe they have an abdominal trauma. Okay. Sometimes they won't. Sometimes they won't have pain there. And it can depend, especially if it's trapped between, because The internal organs don't have nerve fibers like our external, right? There are 20, I always tell people, I have to be like Sherlock Holmes when it comes to the stuff in here. All of it's on automatic. Could you imagine if you had to take a step and you're like, okay, heartbeat, breathe, kidneys work, liver work. I'd be dead. I'd be like, choo-choo. So that's all on automatic. It's functioning whether we have to think about it or not. We don't want to sense it. We don't want to feel our heartbeat. We don't want to feel our lungs breathe or our diaphragm, so we don't feel the inside. It's not until something irritates a muscle that you feel it on the outside. And that is true with appendicitis. You won't feel appendicitis here until the appendix is so swollen it touches the muscle. It's the backside of the muscle, right? Think of a steak, top side, backside. That's when someone goes, oh, it hurts here. Or in a gallbladder, oh, it hurts here. Or diverticulitis, or it hurts here. Otherwise, it feels like the flu. Indigestion, heartburn, upset stomach, flu around the belly button, or down here. That's it. We get 3 spots of pain for internal organs. 1, 2, and 3. Yeah. My brother's a bone doctor. That's way easier. Like, it's broken. Right? No one questions that. Exactly. Good question. Any others on that? So that's probably one of the most commonly, not missed, but missed by everybody walking in the room. Is somebody will be holding their shoulder. We get shoulder x-rays. We all think, okay, shoulder pain. That's why fast scans for us have become so common, because you can't see into their belly. Right? This is the obvious seatbelt sign, right? Right across the shoulder. Somebody coming forward, it snaps them. We have lots of fun injuries that can occur depending on where that seatbelt falls. We'll also get the lap belt. Seatbelt sign, extremely high risk for an injury. It's like 98% chance when they start having these seatbelt signs that they're going to have some sort of injury. At the degree of injury, where it's at, that's relative, but that there is an injury. And abrasions can be seen initially. Bruising is typically not seen initially. We might not even see it in the first hour. These are all people's names. Collins sign. This is a blood here. Interestingly, this bruising and bleeding is actually from the back. Deep, 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 deep inside them. It tracks around under the muscles and can be seen in the front. So other signs, these are bleeding in the back, all in the back. This again, that lovely spine. That is a huge, this is the kidney. It should be back here. This kidney, and that's all that's seen on the outside. This is a massive kidney injury and bleeding. So with evaluation, think of it. Number 1, right? Car accidents, that's the biggest thing is abdominal trauma, is just having that thought process that this person could have an abdominal trauma. Even those people you walk up to and they're walking around, they're like, oh my gosh, were they restrained? You know, frequently we're like, oh, they're fine, they'll be fine, they'll be fine. Okay. We get these people, I was just telling these guys, I had a patient show up last night that had a liver laceration, a pancreatic injury, and a small bowel injury. He was in a motorcycle accident in Spokane, Washington, slid his bike, got back on his bike, and drove himself the rest of the way. Yeah, so he's gonna spend 3-5 days in our hospital. Hopefully we don't have to operate on him. But that's an abdominal trauma, right? He didn't look like it. He didn't feel like it. He got up, gets that instantaneous death we got past, but now we have all these other injuries that can occur. And yes, of course, alcohol is always involved. All right, management in the field. So always, right, the ABCs. This is always the first part. I think when you get to that circulation, this is when you can start thinking about, okay, airways, breathing, and then, all right, blood pressure, vitals, start looking for those bruising, those marks, okay? When you tell us you've seen them, it totally changes what we look at when someone's coming in. It is super useful. We talked about internal bleeding. Internal bleeding is really going to be that C. Somebody would, right? You can lose a massive amount of blood volume, and the only thing you're picking up is that they're a little bit tacky, or blood pressure is just not quite right, and you're thinking, well, maybe they're stunned. Maybe they kind of have that adrenaline response. Maybe they're just, again, you can lose a lot of blood inside that belly. So when we talk about 2 IVs in the field, that's why. This is all built around abdominal trauma. Okay? External bleeding, we talked about the bruising, and it's still treat for shock. Hemorrhagic shock is trauma, right? Blood now is the back. So when I started, it was blood, and then it became fluids, and now it's blood again. And then anything that's open, if you have abrasions, get some wet saline, cover it up, pop it on, cover it with a piece of plastic, move on. Okay. And then idea is get the patient to the hospital, because there is literally nothing you can do in the field for somebody who's bleeding to death inside. We're hopeful we can do something, right? Our sole goal for the pre-hospital into the hospital is to save the person that otherwise would die. If we weren't there for them, if this system wasn't there, they would die. So our whole goal is to stop that process from happening. And we have roughly an hour to do it for some of these patients. The other patients, like the guy I'm talking about, they eventually make themselves into the system regardless. Okay, so this is a really common question. And this is always the slide that's shown. I don't know if somebody mass produced this sucker somewhere, but it's always this picture of the pelvis. And you're like, yeah, I got it. And then you go up to people and you're like, how the heck, where are all these things? I don't know if any of you, I know when I first learned how to do this, I didn't know how to map this out quickly, fastly, and easily on all patients. I'm gonna try to help with that. So, and 40% or more, this is actually a pretty low number, but about 50% of pelvic binders are placed too high. So when in doubt, go lower. You got it. And the problem with that is now you squished the wrong part, and especially where their blood volume is happening. So when in doubt, go lower. And I'm going to show you some simple tricks on how to do that. So abdominal pelvic bleeding, binder. There are a couple of things that you should never, ever feel bad about as an EMT provider. One, needling a chest. Anybody gives you crap about that, you're assessing a patient, you're attempting to save a life. That's an easy fix for any facility, okay? Number 2, an abdominal binder. Number 3, an IO. If you can't get an IV in, get an IO in. You guys are probably better at it than most of the facilities. And if it's there, we'll use it. If it's not, guess what we'll do? We'll reassess everything you just did, and we'll try to spend 15 minutes trying to get an IV, and in the meantime, the patient's bleeding to death. So don't ever be afraid to do those 3 things. You are never, ever gonna harm a patient with a pelvic binder. You will not. So here are pictures of binders. This is the typical open book fracture for people online. Sorry, I forgot to keep saying that. I'm pointing to the first picture. Down at the bottom, you can see this side of the pelvis and this side of the pelvis are wide. That's the open book fracture. The problem with this, yes, is in the front. The bladder has a ton of blood vessels. But right here in the back, as this thing rips open, it rips huge blood vessels on the backside too. So it's not just the open part, it is everything. The second part is this opens that 5 liters or 3 liters wide open. You can bleed as much as you want in that sucker. Okay. This is what a pelvic binder can do, that to that. So can you make a difference on a patient? Absolutely. Here's a patient with a pelvic binder that doesn't have anything wrong. Absolutely no difference between this picture and this picture. This is a solid ring of bone unless you are I mean, so far nobody's ever been able to break a pelvis with an abdominal binder or with a pelvic binder. Okay. All right, so this is always, again, I always love these pictures that I see. This is what they show, because of course we all look like this. So the easiest way to find the pelvic spot to put the pelvic binder on every single human, find their belly button and go down to their bone. That's it. It's that complicated. Belly button, bone. Don't find the hips, don't find this, don't find that. Belly button, bone. And 99.99999% of patients, that's going to be the right spot to put your pelvic binder. Right? Complicated? Super easy to remember, right? Don't have to all that. So I'm all about making things as easy as possible because I don't have a good memory. So if you can teach me something I can remember, and that's one. Now, how great is this? Remember that guy? Belly button, down. Goes right across here, not up here, right across here. And this lady, right? Where's the belly button? Where does it land? I don't know. Super easy. Belly button, down. On all of these patients, this is where they tend to land. Look how low this is. Belly button, down. Belly button, down. Belly button, down. Yep, belly button, down. Yeah, we're just gonna start full body, like, right? You're just gonna put the splint on and connect to this, and then, yes, yeah. And towel, if you come on an accident, right, you can grab someone's coat. A coat works really well, especially if it's not a puffy coat, because those just rip. But if you have a real country coat, then wrap the sleeves around, twist with a stick, right? Simple. Yeah. Questions about where to place a binder? Does that clarify it for everybody? Pretty easy, pretty straightforward, simple. Good. Yeah. Middle of it, right on bone. Snap, snap, snap. It doesn't matter which device. I showed all of these, right? It does not matter which device you use. It's all the same spot. Keep it super simple. That way, when you go to your rig and it's not your rig or it's somebody else's, same spot every time. Belly button right down. If they don't have a belly button, go to the, and I've taken a few, so go to the middle of the belly, go down, bone, straight across, right? And interestingly, no matter how big someone's belly is, you'll find the bone. Yep, you'll find the bone, because if you just lift up, it'll be there. It's the space there is limited compared to how patients are shaped. Make sense? And again, you show up with a pelvic binder on a patient, what am I gonna think? You're worried. I'm not worried, right? You've sent a huge message to our team just by showing up with this, right? Sometimes you just can't say what you think is wrong. You're just like, something's not right. No, you're never, ever gonna hurt somebody with this thing. Has anybody had a pelvic binder put on them in practice? Yeah. So does it hurt? No, you're like, okay, cool, it's a girdle. Yeah, your bones are super strong, your hips, even if you have hip pain, even if you have a hip replacement, no matter what it is, you're not gonna be able to harm that pelvis. Any other questions on that? So my talk is very, very basic. Bruising, injury. Everybody got that? That's my level of smarts. Bruising, injury. Right? Shock, binder. No, like I said, I think sometimes we try to over explain this. Too much anatomy, too much technical talk. It's the same thing I do when I talk about putting in needling a chest or doing a crike. You don't have time to think through all that stuff when you're in the down and dirty, and yet we expect everybody to be able to do this. We want to make it so you're comfortable, and this, I hope, does that. Good. All right, so we went through kind of the definition of trauma, the anatomy, mechanisms of injury. And again, biggest thing with the definition is this does trigger their cortisol, adrenaline. So people will walk around with neck fractures. It's crazy, right? You see the lion chewing on the leg and like, oh, nice lion. Yeah, it's amazing. But at the same time, it's how humans have remained on this planet. The anatomy, really how much blood flow goes through the belly every single minute and how much you can lose really quick, okay? That this area is not protected, it's the most prone, and that it's common that you're not gonna be able to see those injuries because of that. Bellies can stretch, so if you come up on somebody that has that kind of odd looking belly, you gotta assume there's something going on in there. We talked about mechanisms of injury, car accidents, assaults, and the evil bicycle handles. Common evaluation techniques in the field, right? Bruising, and then management in the field. Any questions on any of this? Yeah. I'm sorry, I'm having a hard time hearing. Yeah, you can, and that's true. 4 quadrants means nothing. Yeah, oh, thank you. Good, good. So 4 quadrant exam. Let's go back. Whoops. Whoopsie. I did, I went really back. I'm just gonna show you the belly. And it has to do with the fact of the nerves. We get that all the time. Bowel sounds, like I'm listening to bowel sounds in all 4 quadrants. Well, noise travels, right? And bowels move. So you can say they're super tender in one particular area, but really we just want to know, does it hurt or does it not? That's really what we want to know, because somebody can have an injury. Thank you. Right? We talk about the quadrants, and it really makes no difference to us or to their care, because we can't identify a problem based on what quadrant it hurts. We can kind of get, bruising is far more helpful. And then really what you're telling the physician or the provider or whoever, when you walk in and say they have belly pain, that provider is going to go grab that fast scan and go boom and look. And that's better than any of our abilities, right? Great question though. Touching, awesome, but where and how detailed? All you have to do is, does this hurt? Yes, okay, good, let's go. Yeah, simple and easy, simple and easy. Really what you're trying to figure out is what things are gonna kill them right now in front of me? What things do I now need to tell the team as I get there that I'm worried they injured? And then we do the exact same thing, right? ABCs, it's what things are gonna kill them right now in front of me? And then what things am I worried that they injured that I gotta take care of? Any other questions? Oh, curse sign. I don't remember any of the names, so I apologize. I always tell when I teach, I'm like, there's some old white guy's dead name that's attached to this thing, so I don't ever remember names, and I apologize. Curse signs, shoulder pain. It's going to be, see her grab her deltoid? It's the deltoid muscle. It's so the nerve is, and this is how, again, this is my way of remembering. Nerve, cervical spine, 3, 4, 5. Keeps the diaphragm alive. Yes. So that's where it comes from, your cervical spine, 3, 4, and 5. They give a nerve branch right to here, and then it splits. And 3, 4, 5 goes to the deltoid muscle, and then it goes down, around, into the phrenic. So the phrenic and the deltoid nerve are a Y connector. Right here in the neck, they come together. So if this one's triggered, it hits the other one and goes up to your brain. And then your brain is a computer, and it's going, okay, what is this? What is this? What is this? What is this? And it says, oh, hey, your deltoid hurts. Your deltoid doesn't actually hurt. There's nothing wrong with it. You didn't inflame it. You didn't hurt it. It's a complete disconnect and a computer malfunction. So we call it radiating pain. It's not. It's a disconnect. What other patient do you guys see a lot of that have that? Right? Chest pain, same thing. They have shoulder pain down their arm because the nerve is irritated as it goes back up to the brain, and it tells them their arm hurts. Their neck can hurt, their face can hurt. Yep, same exact problem. It's the same thing all over the body. Our internal organs have no ability to have a direct connect to the brain. How do we know this? I can't make my heart jump a beat, right? I can try, but I can't actually do it. I guess if you do a ton of meditation, maybe you can. But I can do this. I do a lot of this. So we can control all of these nerves, these somatic nerves. We can feel them, we can control them, we can interpret them, and we put a Rolodex or a file cabinet, still aging myself, a Windows file of these pains. But our internal, we have nothing like that. And so they connect to help us. Okay, good question. Absolutely. Yep. They've been at home. Yep. So really common. And it's usually about day 2 because pain gets worse over 48 hours, right? You hurt your knee, the bruising, the swelling, right? Just like any orthopedic injury, our internals do the same thing. We send a few different signals to help. People that are vomiting, really scary. That is one of the scariest things, is a trauma that's vomiting, because we know there's something very bad going on, especially if it's a couple days later, right? So those delayed injuries can be as dangerous. So we really have that hour and then 48 hours. And in between, we're calm. Good question. I'm sorry, I forgot to repeat that. That question was about patients coming in later with pain. Mm-hmm. Bruises. Absolutely. No. Well, good question. So helicopters are for that first hour, right? We have very, very capable providers in Eastern Oregon, extremely capable. And we're becoming more capable. I almost gave this talk on COVID, how it's changed rural trauma. Everybody in this room feels that, right? We actually stopped any transports from helicopters in our area because there isn't a lot of help when we're capable of taking care of that first hour and stabilizing. That's facility to facility. But yeah, no, there's really not a benefit, because those are going to be somebody you can bring in, you can evaluate, and then the local docs can decide, okay, do we need to send this patient to Portland into La La Land, and they disappear and then they get a taxi to get home, right? It's really hard for patients. So it's much better to keep people local. Good question. Anything else you can think of? Thank you guys. This was a fun talk. I really enjoyed it.